Well, let's go ahead and get started. For rounds today, in people filing. It's my pleasure to introduce Dr. Oddis for our round talk today. He's professor of medicine and rheumatology at the University of Pittsburgh. Directs their myositis center there. Really a prominent leader in the field of both clinical care and clinical outcomes research for patients with myositis and autoimmune myopathy. Very briefly, he has numerous important leadership roles in various national and international bodies like the ACR, the Myositis-Associated America, the International Myositis Assessment and Clinical Studies Group, or IMAC. If you look him up in PubMed, has a prolific list of publications and works that he's authored on a variety of topics. Is a leader in studying novel therapeutics in myositis, was one of the two guys of the RIM study, leading other ongoing trials in myositis, with her interest in epidemiology, disease classification, interstitial lung disease, an extensive list of honors ranging from being a top doctor in the United States to a master in the American College of Rheumatology. And so I'm excited, as I imagine you are too, to hear his talk today on updates in inflammatory myopathy. So please join me in welcoming Dr. Oddis.
Okay, thank you. Is it on? Okay, good. So, thank you, James. This is what I'm talking about. Used to be able to do this in an hour. Can't do it in an hour anymore, but we'll try to cover what I think is relevant and get you some updates on things. These are my disclosures. And you have to remember, when you take care of a rare disease, pretty much say anything you want because nothing's approved, and so we can get away with it with the small number of studies that we have. But this is what I'm going to cover today. I'm going to cover some selected clinical features of myositis classification. I'm going to talk about autoantibodies. I've kind of spent a lot of my career talking about autoantibodies, and then we're going to talk about selective treatment aspects, particularly one that kills our patients with myositis, and that's lung disease. So this used to be a simple classification in old textbooks. I'm not going to read there. There were 6 things. Actually, IBM came up, and obviously that's one of the newer kids on the block a few decades ago. But it's gotten complicated and gotten interesting in myositis for lots of reasons. And this is old criteria. 1975. Okay, again, I won't read the Bohan and Peter criteria, but those of us with gray hair recognize these criteria. Okay, and then there were problems with this criteria as we've evolved through the years. One thing was that there was really no good way that you could exclude other myopathies, the so-called mimics. Okay, that was a problem. And then there was misclassification of IBM and PM, and then the criteria weren't explicitly defined. So obviously we had issues in myositis, and just over the past year, 2 years, we now have new criteria. And I'm not going to go through how these criteria were developed. I was part of this process, and it's really boring to go through how these things are done, to be honest with you. And I'm not telling you it's a lot of work, but it can get a bit cumbersome. So I just thought I'd kind of try to highlight these new criteria. And it was an ACR EULAR initiative, and it was led by Ingrid Lundberg and others. And basically, you get candidate variables. You assemble this stuff. You get a good group of experts involved. And we collected data not just from rheumatologists, but we included rheumatologists, neurologists, dermatologists, peds people worldwide. And the nice thing about this criteria is that it's weighted. There's certain criteria that mean more in a classification process than others. And then you get a total score. And that kind of corresponds to your probability of having an inflammatory myopathy. So I'm going to go through every one of these. There's a little, so you can actually go online and calculate, web-based calculator to kind of use these different criteria. And, you know, you can come up with a probability of criteria. And again, the bottom line is that if your patients don't have a classic dermatomyositis rash, you better do a muscle biopsy, because there are mimics that I'm just going to talk about very briefly that can confuse you. And that's the whole idea when you do criteria. You have to deal with the mimics, okay? But if your patients do have DM, you don't necessarily have to do a muscle biopsy, but there is a recommendation that you do a skin biopsy. And then finally, as I said, these criteria provide a score and a probability for having IIM. IIM is idiopathic inflammatory myopathy. Again, as we know, classification criteria mainly for clinical trial purposes. So this is now out there, it's new, and it's relevant. And I showed this slide yesterday when I was talking to the neurologist briefly. And these are all the different types of skin manifestations that we see with dermato. You know, we obviously know Gottron papules, and we know, as I said when I talked to them yesterday, this lady came to me with a history of psoriasis, and she had muscle weakness. Well, she didn't have psoriasis and muscle weakness, she had dermatomyositis. And then this is a patient that we're going to talk about later on. They can have ulcerations and look like vasculitis. And of course, if there's any students here, there's no nasolabial sparing. So this is not lupus, right? And then this is a guy who slapped his hand down next to his thigh, so you can see both his Gottron changes in his holster sign, all right? And then finally, the heliotrope, the V-neck sign that can be just like lupus, and of course, this one is the shawl sign. So there's a lot of different cutaneous manifestations. So whenever a patient shows up with any of these and they have muscle weakness, as I was talking to the group yesterday, that's not a hard diagnosis. It doesn't mean it's easy to take care of, okay? It doesn't mean this is all easy stuff. But you need to know that this is dermatomyositis, and that diagnosis is not challenging, really, to make. And by the way, any questions, just interrupt right in the middle. I'd rather have that and have a good exchange. So as I said, if you go back to our short list of the classification, which I'm going to change in front of you today, this is dermato, all right? And this is adult dermato, although some of those things can certainly occur in juvenile dermatomyositis. And as we were talking last night, sometimes the skin, and I'm going to filter in and kind of sprinkle in treatment as I go through this, and you never quite know how to organize things, but you know, you can, again, you can react with any questions you can, but sometimes the skin can be the most dominant feature that I deal with and that our dermatology colleagues deal with. And we see that a lot. And this is for example, these are 3 patients here that had an outrageous scalp rash. And scalp rash can be so pruritic and painful at times. This is a lady that I've seen for many, many years. This is a lady that couldn't even wear glasses, you know, because of the rash. And then this lady was suicidal because she couldn't get away from her scalp, you know. And these are tough. And you know, these are patients that have been treated pretty aggressively with different features. So when I talk about cutaneous manifestation, I'm not going to go through this entire algorithm. This is kind of like what you know, the way I think of it. And obviously we do the simple things, the sun protective features, and sometimes topicals will work. Frankly, I don't think Plaquenil does a whole lot, and I've seen patients with Plaquenil developed an erythroderma. Okay, so I've made DM patients worse by putting them on Plaquenil with a pretty diffuse erythroderma. I don't have a good explanation for it. It seems to be more, to me, in dermato than it occurs in lupus, but I don't know why, but that's what happens. So anyway, we've got some simple stuff, all right, and sometimes they do okay, and we give them some prednisone and it goes away, and then sometimes we treat it just as aggressively as we do the systemic manifestations. They get methotrexate, they get Cellcept, they can get IVIG, and even other more aggressive therapies. So you know, when you deal with this enough, you know that you have to hit some of these patients hard, and they just have bad disease. So we looked, you know, we still had patients that were having tough disease, and we thought we'd kind of use different novel approaches. And I believe that some of the medications that we have actually that are going to work for psoriasis are going to work for dermato. I think just need to be studied a little bit better. But this is a patient, again, I just want to share, this is a patient that has what's called the TIF1 gamma autoantibody. I'm going to talk about that later on. That's one of the myositis-specific antibodies. And look what she got treated with. I mean, I'm not going to read everything there. That's pretty much everything. And she never got better. And she had a terrible scalp rash and itchy elbows. And we gave her, actually, a dermatologist that I worked with got apremilast. I said, do you have anything we can do? And he gave me apremilast. And I saw her this week, and it's now been 2.5 years, and she is rash-free on apremilast. This is one case, okay? That's why I said, you know, this is just one case. But this is a very good example on a patient that had a ton of refractory interventions. We then wanted to look at tofacitinib. And this was, and again, these were published, as you can see. This paper was just a case report last year, and this is another case report from a junior faculty member. So these are patients that got treated with tofacitinib. And I just put over here again to convince you, they tried a lot of different immunosuppressive agents, okay? And this lady is still in remission, mildly active. This is another one who had bad disease. This is a young kid who still likes to play sports and softball, and his rash always got worse when he worked out. And I actually have 2 or 3 others. So I've had at least 5 or 6 patients now that have responded very nicely to tofacitinib in terms of their skin. And in fact, some had an inflammatory arthritis. As you well know, tofacitinib is approved for rheumatoid arthritis. I haven't really used it significantly for bad muscle or bad lung, but you know, I think it warrants a pretty, you know, I think it warrants an approach to use these JAK inhibitors. So I added 4th line in my algorithm here, and that's to consider tofacitinib and apremilast. And in fact, I think the IL-7, anti-IL-17 inhibitors as well. I don't know if dermatologists have any, any experience with secukinumab or others, but I think that might work. So, as I said before, the problem is oftentimes polymyositis. And the problem with polymyositis is this, is that there are a lot of mimics. And before you label somebody as having autoimmune myositis without a skin rash, you better make sure that you've looked hard at some of the other things that can mimic myositis. And this is a lecture in itself, so we're not going there, all right? And the ACR has often had lectures, and I know the neurologists have often had lectures on the mimics. I just thought I'd talk about a couple of them. But the point is, though, that if you do have a patient with, quote, polymyositis, and we're going to come back to that concept in a little while, you need to do a muscle biopsy. And it needs to be looked at by a reasonably good neuromuscular pathologist, because there are those mimics out there that we need to be concerned about. You don't want to be treating a patient with dystrophy, atypical dystrophy or limb-girdle muscular dystrophy, with immunosuppressive medications that might cause problems, and the list goes on there. So muscle biopsy is a must. And just from a perspective, I can remember when I started this 30 years ago, over 30 years ago, kind of used to think, oh, polymyositis, slap on a rash, that's dermato. That's what it is. But that's not the case. These are 2 different diseases. Even though they respond similarly to immunosuppressive therapy, they are 2 different diseases. And one of the features of that convinces you of that is the fact that the histology is different, okay? Here you have polymyositis dominated by lymphocytic invasion of non-necrotic fibers that can occur in IBM as well, which we're not talking about today. And you get the perimesial, perivascular, CD4 positive T helper cell infiltration. And then when you look at dermato, it's a different histopathologic animal, okay? These patients have perivesicular atrophy. You can see atrophy right here. You look in the middle of the fascicle, they're more plump. You get perivascular B cells. You get complement deposition, MAC deposition. You get CD8 positive cells. You do get some perimesial CD4 positive helpers, but it looks different, all right? It almost looks like a vasculitis in some instances. So the histology is different between the 2 major subsets of disease. Not to mention the fact that over the past decade now, maybe 8 to 10 years, we've got another new kid on the block that you guys know about, and that is necrotizing myopathy, okay? So that has kind of come into the picture. And what we called PM before, in some cases, we are now calling necrotizing myopathy. So let's talk a little bit about necrotizing myopathy. That's not a typo, okay? And I don't know, who's from neurology here? Okay, yeah, okay, so here I am, Michael, this is what I was talking about. So this is not a typo, all right? It's little now, right? Why is it little? And the other ones are the same. Well, maybe it's because of this down here and some other things. So 17 years ago, this article came out, and you know, these are all these dang neurologists here. I'll put this article out here. So I look at this article, and you know, I'm kind of in the middle of my career, and Fred, you know, some of you guys know Fred Miller and others, and so Fred and I said, well, we got to write an editorial about this. You know, get these guys talking about overdiagnosed entity. And you know, so through the years, we basically eat crow, because it is overdiagnosed as these other things have come into the picture, all right? And in fact, even rheumatologists, Troy Oddis from Montreal and his group actually a couple years later said, well, maybe we ought to look at myositis in a different way and really start talking about overlap. So it basically becomes a matter of semantics, as you can see here. So as PM shifts over into some necrotizing and has PM that's antibody associated, ends up having other autoimmune manifestations. So you can see that perhaps this bullet gets a little bigger, all right? PM stays low and necrotizing comes into the picture. So is it a big deal? Well, in some cases it is a big deal, because if you're doing studies and you're doing clinical trials, then you'd like to be able to classify people as well as you can. In my estimation, I still think autoantibody classification is the best. It makes more sense to me. And Pestronk might say pathologic is good. And Michael, you can comment on that later on. But this is kind of in a short, you know, variety, in a short form, how I'm starting to look at this now. Which brings up this first case, and these are real cases. I kind of sprinkle in some cases here, and you can comment along the way and ask questions. But this is and I want to make some points on this case, and you'll see that this is a few years ago, okay? This is a patient that I didn't see probably until 10 years ago. But she's a 67-year-old lady with hypertension and has dyslipidemia. She gets put on atorvastatin, all right? Look at the time difference, the timeline here. She's on that medication for 4 years. And then she gets weakness. She doesn't go on it and then get weakness a couple months later. She's on it for 4 years. And I take pretty careful histories when I talk to these patients. And in fact, 1 year later, she starts having difficulty from a functional perspective, okay? And her daughter goes on the internet 10 years ago and says, yeah, I think it might be the statin. Let's stop it, Mom. And she stops it, doesn't get any better. And then a few months later, she said, she goes back to her doctor, who doctor just said she was getting old. She goes back to the doctor and says, you know, something's going on here. I can't get stuff out of the cupboard, the closet. I can't bake cookies and post it on. I can't get up on the footstool and things like that. He says, okay, I'll check your CK. He checks 6,400, okay? And he says, I think it's a mistake. And she fired him and went to a different doctor, and repeats it, and it's 9,000. She gets admitted to the hospital. Again, this is, 10 years ago, all right? And she's got muscle biopsy. She's got myonecrosis. She does not have lymphocytic inflammation. She's got necrotic muscle, all right? And there's no autoimmune component to it. And this isn't her, but it could be her. The necrotizing myopathy patients, if you'll see necrosis, correct me, Michael, if I'm wrong, necrosis, but not much lymphocytic inflammation in this biopsy. This is a necrotizing myopathy, okay? And she gets treated with prednisone, followed by methotrexate immuranum combination, and later gets IVIG, and she normalizes her muscle after I had seen her, okay? And when the test became available, I don't know how long it's been available, maybe, I don't know, 6, 7 years now. She was anti-HMGCR autoantibody positive, okay? So I was seeing these patients, and we actually looked for antibodies in these patients, but we didn't do the sophisticated testing that Andy Mammon did at NIH, at Hopkins and then NIH, because he identified this doublet. It's an anti-100, 200 kilodalton doublet that these patients see. And when one of the autoantigenic targets ended up being HMGCR, which is really interesting. The antibody, or the molecule that statins inhibit, is actually the autoantigenic target in these patients. So this is again a lady that responded very nicely and finally completely to IVIG. And, you know, just to cut to the chase a little bit regarding some issues with treatment, and I know James and others, even in neurology, have talked about using IVIG. What Andy suggested in I think it was a brief editorial about 5 years ago, was that maybe the best thing is to give these patients IVIG right off. They're older, they're steroid sensitive, right? I mean, with the glucocorticoids that you give, and they respond pretty well to IVIG. Now, it's interesting that I do use IVIG a lot. We published a series on that as well. But it seems that many times the CK stays elevated, and it doesn't normalize. Some it does, but sometimes it doesn't. And sometimes it doesn't, and I've added other immunosuppressive medication, and sometimes it doesn't, and they don't get necessarily weak again. So I don't have that figured out. I don't know if you want to. Of IVIG? Yeah, yeah. And so Michael is saying 2 grams per kilo every month and what Andy would say is many months sometimes. He's keeping it going. Now, we use 2 grams per kilogram, and we either can do the 2-day regimen, remember 1 gram per kilogram, 2 consecutive days, or 5 times 0.4, which you sometimes have to do in these older patients if they've got cardiac disease. You have to watch the volume, because it's a big volume, okay? So you can do the 5-day, 5 times 0.4, or 2 times 1. But I try to, you know, people always ask me, well, how do you get them off IVIG? I just, it's trial and error. I go from 2 grams per kilogram per month, and then I'll drop it to 1 gram per kilogram per month. And then I might increase the interval of administration, or I might go to 500. So I play with it, and because, you know, I want to be fiscally responsible, because these are very expensive medications, all right? So I'll try to get the dose down as much as I can. But anyway, I just put this up here as, you know, as a plug for IVIG. And then there's other uses of IVIG. I just thought I'd throw this in here. You know, IVIGs, again, I probably use it more now than I did earlier in my career, but when is it good? Well, it's good whenever you have, let's say, for the most part, unless you give these people aseptic meningitis, which I've done on a handful of patients, and they don't like you very much when you do that, but it's steroid sparing in the setting of infection, right? It's effective for esophageal involvement. It's good for the acute or rapidly progressive disease. It's effective for the refractory rash, and it might be the drug of choice, like I just said, for a statin. So IVIG is a good drug. You just got to be careful how, when, how much, and how frequently you use it. Well, there's another necrotizing myopathy, right? And you people should know this. Rheumatologists should know about anti-SRP, anti-signal recognition particle. These autoantigenic targets are really interesting in myositis, and people like Keith Elkon really should be figuring out why we target all these crazy autoantigenic targets. It seems to be involved in peptide synthesis and other things. But the point is that these patients with anti-SRP are quite weak. In fact, to me, I put down here, they look like they have a dystrophy. I've seen patients that come in with chronic SRP and they kind of walk like this because they're so atrophic that they have to alter their center of gravity, essentially, and walk, you know, so that they can balance themselves. But that's necrotizing. Sometimes I can't tell, you know, looking at it with our neuromuscular pathologists many times, that it's SRP versus HMGCR. So they're necrotizing. They, or what I said, PM phenotype, but they rarely have a dermato rash, and they rarely have ILD. We've seen some other sprinkled stuff. It's interesting, just for your own, and I think it's correct that if you have anti-HMGCR, you usually do not have any other autoimmune manifestations. You have muscle. But when you get SRP, which is a necrotizing myopathy, I've seen scattered Raynaud, joint pain, a little bit of ILD, sometimes not, maybe a rash or something. It looks like, so it's a good way to tell. And then of course you can tell by getting the autoantibody profile, but it's just interesting. And in general, this is again a refractory subset. All right, this is a tough one to treat. You know, this is poor response to therapy, variable prognosis, and again, this is a nice picture. And here we are, necrotizing myopathy without inflammation in an SRP group. Necrosis, no inflammation there. Okay, just necrosis. So what works in SRP? That's a bad actor, right? SRP positive necrotizing myopathy. I'm not going to talk about the rituximab study. We did that study out of Pitt. It was a $8 million NIH-funded trial, and we looked at a big cohort of patients, and we found that those SRP patients actually did respond to rituximab. And there was a smaller study out of Hopkins, an open-label study looking at anti-SRP. So I do think it's, and I'll show you a little bit more later on. I do think that SRP maybe is one autoantibody subset that's bad that responds to B cell depletion. Okay. So now we have filled up our, our new classification a little bit more with a couple different entities, and we're going to add another one, and that is amyopathic. Yes. Oh. Yeah. Oh, those are great. What was the first question? Do I use in the HMG? Yeah. Oh, yeah. Yeah. Okay. So let me address that. So the question is, let's take the kind of refractory HMG-CR patient. I'll give them IVIG. Let's say they don't respond great to IVIG. And I will add methotrexate and other immunosuppressants, but let's say I come to rituximab in that population. Yes, I do. I'm not so sure it's as clean as SRP, but there is data out there that rituximab, the B-cell depletion, does treat anti-HMG-CR antibody positive necrotizing myopathy. So yes, so the answer to that. And then the second question you had, what's this mushroom thing you're talking about? Okay. Does anybody know about that? Huh? Yeah. So Andy has done some work on it. So he couldn't. Some of these patients with HMG-CR positivity, they don't have any history of statin exposure. Okay. But he does have a couple patients that actually took supplements, and one of the supplements that the patient took was it shiitake? Is that what? Yeah. And what he found was that he asked this patient, he goes, "Do you do anything else?" He goes, "No, I don't do anything." And his wife said, "Yeah, he eats a lot of the thing he bought on Amazon appropriate." And Andy went and looked at what he was eating, and what it was there was a lot of this mushroom type derivative. And what do you think was a big component of the mushroom derivative? Statins. So this patient actually was actually not taking Lipitor or atorvastatin or anything else, but was taking a supplement, a statin, that was actually doing the same thing that the statins do. The second question on that is, I think you were saying, how do you counsel these patients? That's an issue, and it's very interesting. And I took those slides out, but I'm going to digress here a little bit. So why, if they stop taking, oh, that's somebody on that. Okay. Why, if they stop taking a statin, do they have ongoing problems? You might know? Yeah, Andy did elegant work with this. Yeah. So we know muscle regenerates, right? Okay. And when muscle regenerates, what he showed was that HMG-CR, even without the ongoing administration of a statin, HMG-CR is still expressed on the surface of the muscle fiber. How weird is that? So even if you're off of the medication, and by the way, you should never go on a statin again when you get NM, all right, from a statin. You don't go on it again. You stay, and then it's a long-winded answer to your question, I'm sorry. But this is important because you have to avoid statins in whatever you're eating, because if you continue to take statin, eventually that might exacerbate the ongoing inflammatory attack on your muscle because of the ongoing presentation of the autoantigen on the muscle fiber. It's a fascinating thing, and he did that in very elegant experiments. Well, it might be, and I've had that question, Michael. I guess I tell them to avoid it. I just think, because who knows? I mean, if they're getting this disease, right? I mean, how many people get statin necrotizing myopathy, it's really, really rare, okay? Because these statins are like, what, how many million people are on them? But if they're getting it, then something's weird about them. And Andy has shown they have a genetic predisposition. There's genetic markers that predispose to the myopathy. So if they're getting it, then obviously their immune system is a little wacky, all right? Like all of our autoimmune patients. But the point is that there's something about their immune system, so you probably ought to avoid any. Okay. Yes. Yeah, that's a good question. So in other words, is this a durable autoantibody response? And in general, it is. We've looked at autoantibody titers over time, and in fact, we've wondered, JO1, SRP, HMGCR, they usually stay positive, but Andy has actually reported that the titer can go down in anti-HMGCR. I don't know if he's reported that it goes away completely. I think a couple of his patients have, but I don't know the data. But for the most part, and for most of these autoantibodies that we've reported previously, it doesn't go away completely. But we have shown reasonably good data that titers vary over time with JO1 and others. And Dana Asherman, who's now with us, and some of the other people we've collaborated with, have actually shown that sometimes the titers correlate with disease activity. But don't go away completely. Yeah. Oh yeah, flagellate. Yeah. Yes, it had that. Yeah, that linear flagellate erythema, right? Is it called? Oh, really? Like anybody? Wow. Something about that mushroom. Somebody else had a question, or?
Genetic question.
Yeah.
You're going to try to talk more about treatment with necrotizing. I just sort of, it came to mind. Have you ever had a patient go into complete remission?
Yeah, on IVIG?
On
yes. Well, actually, I don't think I have. I've spaced it out very nicely, and I probably don't have the big number that Andy and others might, but we have a fairly good one. And I think Rohit Agrawal, you guys know, collaborates, works with me at Pitt. I think he does have somebody who came off, but I'm not sure. I wouldn't be surprised if they recur, even. But why do you have some? Yeah, I think I do have one. But isn't it crazy that most of them it's an autoimmune disease and it doesn't go away? Mm-hmm. Right. Yes.
Generation of anti-CD20 complement antibodies.
No, we don't have any. What? I can't remember the name. Yeah, it's a long name. I can't remember it. No, I don't, and I don't think genetics is going to be interested in doing anything. I think that's a Genentech molecule. It might be. Yes. Doesn't it get into the tissue deeper? They say, is that what it is? Yeah. Right, which means that why it might work better in kidney, in nephritis, right? Yeah. Well, yeah, possible. No, I don't have any data on that.
I didn't finish.
Okay, where are we? So amyopathic. We're going to go in a little different direction now. All right, that's kind of become used to be amyopathic. Okay, treat the skin. The muscle is not going to be an issue. And then we learned more about amyopathic over the years, haven't we? And that's also more recent. And then actually we learned from the Asian literature, all right? Japan, they had this, goes back 10, 15 years. We've got these patients showing up with rapidly progressive ILD with amyopathic dermato and really no muscle, okay? They just don't have muscle. They don't have much of anything else. And then it was in the Chinese literature, and then in other Asian populations. And then they found that these patients had first of all, they found that they had a CAD, means clinically amyopathic dermato. They had this 140 kilodalton band, all right, on immunoprecipitation, and then it was identified as MDA5. Well, what's MDA5? MDA5 is a cytoplasmic protein that senses viral RNA. So you get a virus or something like that, you get some kind of antigenic stimulus, and that MDA5 is kind of fired up in your system, okay? It senses something, and so it's involved in innate immune defense against viruses. So to me, that kind of supports the role of some kind of viral trigger, because these people get sick pretty quick, all right? It's not like they slowly evolve. Most of the time they get a little sick, then they worse. It looks like they get some kind of infection or some kind of trigger, environmental, and they take off, all right? And it kind of makes sense if MDA5 is involved, because MDA5 is going to respond to a viral type RNA. So that's interesting. And then, you know, our derm colleagues, Dave Fiorentino, who some of you know at Stanford, you know, started looking at this when he was doing some work with the guys at Hopkins, and he found this very interesting cutaneous phenotype, ulnar papules. That's vasculitis. Come on, that's what we see when we see vasculitis. So he reported these pretty significant vasculopathic manifestations with anti-MDA5, all right? And this is the second case that I saw whenever I didn't know anything about this antibody. So I get called from a person in Chicago about a 70-year-old guy who had double pneumonia. Now, just bear with me. If you hear double pneumonia can occur. If you hear double pneumonia as a rheumatologist, keep your eyes and ears open that it's going to be autoimmune, okay? So this guy has double pneumonia, and the guy calls me and says, because it looks like he's got lung disease that didn't go away, and he's got a rash, all right? And I said, geez, this could be something bad. This is before MDA5. And I said, I'd give him cyclophosphamide and steroid and then follow it up with another immunosuppressive agent. So I saw the guy about 3 months later, and I said, oh yeah, this doesn't look good. He goes, oh, it's really good now. I said, oh, and he said, plus I'm breathing really well. And I just took pictures of him. I didn't know what it was. I mean, I see this stuff, and we didn't know this many years ago. And he had a necrotic finger, and he had this there, and doesn't it look a lot like that, right? Okay. So again, whenever I remembered what this guy had, and the assay that we could find, he ended up having anti-MDA5, all right? And he got better, and he never developed muscle, right? 7-year-old guy, strong as an ox. And then, this is a little bit more recent, but I have, you know, a lot of these. So this is, and look at this is the timeline here. Look at I put it up because of the timeline. So in the summer of 2012, this patient has a rash. It's photosensitive. And then she sees one of the fellows that I trained that lives up in Erie. In January, she's got polyarthritis, mild muscle weakness, gets her workup. I'm not going to read everything there. She gets better, okay? Low dose prednisone, a little bit of methotrexate, things are better. And then she said, well, I want you to go see Oddis in Pittsburgh when the weather breaks. So she comes down in May 2013, okay? And she's got a bad rash. I'm sorry, the rash isn't that bad, okay? And she's got crackles on pulmonary auscultation. In other words, I'm talking to her husband. He's sitting over there. I'm talking about his back pain. So I listen to her lungs, and I hear crackles at the base. I said, do you have any problems? She goes, no, I'm fine. And in fact, she says, I check my muscles because I have to walk up 2 or 3 flights of steps, and I'm having no problem going up steps or walking up. I said, okay. Well, I want this. I sent a note back to our fellow. I said, get an HRCT on this patient and get some PFTs. This is a baseline, because I was kind of concerned. And I recommended just a bump in prednisone. And I added CellSet because of her skin, basically. Okay, so this is May 2013. I presented this at other ones. Forgive me if you've heard this before, but so this is, she didn't get it next week. She got it a month later. She got a CT scan because she didn't feel badly, okay? And but this is not a normal CT scan, right? She's got some changes, some reticular changes, but it's not that bad, is it? I mean, there's something there that makes sense based on the crackles I heard, but it's not that bad. Okay, so remember, May 13, I see her, June 6th, July 2nd. I'm giving grand rounds at Cleveland Clinic, and I kind of got called around the holiday by the fellow, and it's actually a different fellow who also trained with us and said, hey, Chet, this patient shows up in the emergency department, she can't breathe. And then it hit me because I knew about this antibody. And I said, and I'm not sure, I have it here. I said, is there anything going on in her hands? He goes, yeah, in fact, she's got these things on the palms of her hands now that she didn't have before. So this was her CT in June, 1 month before. This is her CT now, and she's dead 3 days later.
Oh my God.
With nothing. I mean, when I saw her in May, nothing going on. And of course, she's anti-MDA5 positive. And this is, so I remember the group from Hopkins said, well, MDA5 isn't as bad in the American population as it is in the Asian population. And I remember talking to those guys. I said, I don't know about that. And so we did a study, actually, of a case control study, and we done by CMAC. He was a former fellow and now a faculty member a couple years ago. And we looked at a matched group of MDA5 negative, 106, MDA5 positive, and you don't want to be on this survival curve, okay, of the MDA5 positive. Now, that being said, we do have many MDA5 positive patients who do okay, all right? It's just something about some of these where they fall off the edge of the cliff, and she was one of them. It was just devastating to see that. So this was published a few years ago saying that, indeed, anti-MDA5 positivity in the Caucasian population can be as bad as it is in the Asian population. And just to further convince you about what Dave has reported, these are two patients. Now, these two patients, one up here, one down here, no lung problems. But I saw them, and look what happened over 3 months period here to these fingers, all right? And it's really all skin, vasculitic, down here. A young woman who played really competitive high-level volleyball, okay? And then she gets a necrotic finger. So it's a vasculopathy. Again, no significant lung disease in these patients, all right, in these examples. So now we've gone through a couple of these antibodies, and we've talked about necrotizing, we've talked about amyopathics. We might come to a couple over here, but now everybody knows them. Yes. That's okay, so the question is, I see a patient like the one maybe here. Should we jump on these patients and say, okay, we got to give you something really aggressive because you're gonna degenerate, you're gonna deteriorate into a more rapidly progressive ILD? That's the question here. I get that question a lot, and I don't want to be cavalier in any answer because we always try to be evidence-based. The trouble is we don't have a lot of evidence, do we? Because we don't have in other words, we don't have a cohort of those patients with mild disease, because I can tell you right now, there are some of those mild patients who will remain mild, and they have remained mild. So I can't say that every inkling of interstitial lung disease needs to be treated with rituximab or cyclophosphamide. I wish I could tell you a better answer. It's the best I can do. But I think what you do, though, excuse me, you watch them like a hawk. Understand? You get baseline PFTs, you get a baseline HRCT, and you don't have to get serial HRCTs because there's a radiation exposure, but you get them, and then if there's any clinical, and you get PFTs though, maybe every 6 months. That's fine. That's not minor. No big deal. And if there's any clinical change, you jump on an HRCT with imaging. Yes. Oh, yes. Oh. Do you know of anything in the literature that shows that? There is, actually. There is. Yeah, there is, actually. So the question is, sometimes patients with ILD seem to have a high ESR. I wasn't sure I believed that when I see it, but it might be true. So that might not be a bad idea. If a patient has mild ILD and they have a high ESR and you don't have a good reason for it, maybe they weren't closer follow-up and maybe even more aggressive therapy. The other thing about these MDA5s, there's literature out there on looking at the ferritin. The ferritins are off the wall in these patients, okay? And that was reported in the Asian literature, and actually can be a biomarker. In fact, I think it's if the ferritin exceeds, I don't want to say the wrong thing, guys, but if it's 2,000 or 5,000, if it's like dichotomized, if it's really high, then you better watch them because they're gonna be, that's a bad prognostic sign. So it's sort of an answer to your question, but not totally. You had a question too. Yeah, I'll talk about that. In fact, I'm going to talk about it now. Now we're going to talk about, and you guys all know what anti-synthetase syndrome is. I mean, we know that it's been around for a while. Sometimes, people still miss it. So those are the manifestations. And of course, I highlighted this, right? Because you're not going to die of your myositis. You're not going to die with your inflammatory joint pain or your rash, but you are going to die potentially with your ILD. So these are the different features. This is a nice picture of mechanic's hands up here. This is a deforming arthropathy that you can get. This is Raynaud, and then this is your ILD. So these patients can have all of those manifestations. But I'm going to talk about this in a little bit different way that we published. So it's not new data, but I like to educate people because I don't think everybody realizes. The skin rashes and the myositis can be subtle and mild, not even non-existent or subtle. And these patients can have lung-dominant disease. Now, this is an MDA5. This is synthetase, okay? And this is a patient, again, this is a patient, look at the date. I saw this patient in January of 2001, 39-year-old lady. And I could put other ones up there, but some of these are just interesting. And she's hospitalized with an FUO. She had really nothing else. She had fevers at home, got to the hospital, was found to have a low titer ANA that kind of fluctuated. And she had basilar pulmonary fibrosis. And we get consulted on her 20 years ago. And we can't figure it out. We don't figure anything out. And it was interesting though. But what I did is that I said, I'm going to pull some serum on here and stick it on our lab when, we just kind of consent her and put it in the lab. And she smart lady, she signs out AMA. She says, you guys don't know what I have. I'm leaving. But she's not that sick. And then 2 months later, I see her in the office. And she's got worsening myalgias, arthralgias. She's got small pleural effusions. She's got fever again, Raynaud phenomena. And I said, look, I don't know what you have, but you have UCTD, all right? You got something undifferentiated, all right? And it may be then that I got the sample. I said, but I'm going to draw something, just see if anything comes up. No weakness, okay? 1 month later, her dyspnea is worse. She's got diffuse pulmonary infiltrates, very subtle Gottrin changes. And that serum that I ordered on her, it came back in our research lab with anti-PL12, okay? Not anti-Jo1. So she's anti-PL12. That is an anti-synthetase. We'll talk about that. It targets a different aminoacyltyrrhinase synthetase. And subsequently, this patient has worsening infiltrates, and these are her numbers. This is a 39-year-old lady. These are not good numbers for a 39-year-old woman with twin boys who said, I want to see my boys graduate from high school. That's your job, okay? Pointed at me. I was afraid of her. But she was a nice lady. And she's got rash and joints and never comes back. Never develops myositis. 18 years later, these are her PFTs. They're not normal, but they're pretty good, all right? And what did I treat her with? Tacrolimus. You asked about tacrolimus. No prednisone. She's on no prednisone now. She's been on tacrolimus for really almost 18 years now. And she responded to tacrolimus and never had any other immunosuppressive agent. So, I'm going to come back to the tacrolimus later on. The point that I want to make here is that the anti-synthetase syndrome is a nice thing of 6 groups of symptoms, but many of these patients, they don't present with a classic anti-synthetase syndrome, okay? So you better keep your eyes and ears open for autoimmune ILD with this group of antibodies. Now, Jo1 is the most common, and it's really the most common by a long shot, all right? But these other ones are in there too. And why in the world do you target an aminoacyltyrrhinase synthetase when that's ubiquitous in your body? This is the enzyme that hooks up the amino acid with the tRNA, hooks it up in a process of proteins. There's billions and trillions of copies in this room, and you don't have anti-synthetase syndrome. We can talk about that later on. But what I was seeing through the years, and this is our cohort years ago, this is an older slide, this is the benefit of a registry. When you can look into your data and see that you've got 140 Jo1s and all of these non-Jo1, but all synthetases such that you can break it down like this, okay? So this is what we did. And because it was my thought, and I remember when Rohit Agrawal came to Pittsburgh, I said, Rohit, I think, he likes statistics and stuff like that. I said, so you can figure this out statistically. I said, but I think that these patients with Jo1 are different from the non-Jo1, okay? And so what we did is we looked at that and we published this. This is not new, but I said, we take pretty careful histories on these patients when they show up. So we had their clinical data, all right, on what they presented with, what they had, and then we compared it the non-Joe 1. This is a case series. This is 122 Joe 1 patients with 80 non-Joe 1 patients, and their first symptom. Look at it. Over here, or their first diagnosis, I'm sorry, we still had PM over here back then, but the point was that these patients had myositis, okay? PM or DM or an overlap. But look over here, these non-Joe 1 patients, they were a little weird, all right? They had half of them. The first diagnosis was, you got something that I don't know what it is, right? Okay, it's undifferentiated. And there was DM and PM in there, even scleroderma in these patients, okay? So that was interesting, and that was statistically significant because there was a statistically different in myositis, 83% of the Joe 1, only 39% of the non-Joe 1 as the first diagnosis, as you can see there, significant. What else about this cohort? Well, the non-Joe 1s, when we looked at it, and we had the data, because we followed these patients longitudinally, some of them close to Pittsburgh, others not, we found out that the non-Joe 1s indeed had a worse survival. So the point is, why do they have a worse survival? And my point was that I thought it might have been due to a diagnosis delay, because you don't have the classic symptoms to make the diagnosis. And what was the delay? Well, the Joe 1 patients had their diagnosis made in 0.4 months. The non-Joe 1s, it took a year to make the diagnosis. And that, again, was a statistically significant difference in the time from onset of symptoms to diagnosis. Looking at I cut a lot of the slides. Looking at how do these patients die? They die pulmonary deaths, regardless of whether they're Joe 1 classic or non-Joe 1. As you can see here, half of them died of pulmonary fibrosis. Another 11% died of pulmonary hypertension. Now, this pulmonary hypertension, you know what it's like? It's like the limited systemic sclerosis patients. They have primary PAH and not hypoxemic-induced deterioration over time, but it's primary. And of these patients over here that died of other things, they also had lung disease. They just died of something else. So the point here is that in the synthetase positive patients, you better pay attention to the pulmonary. Yeah. Come to that at the end. I added those slides for you. Okay, and I'll talk about it at the very end. I put in slides on that. Yeah, there's some really really good data from Wakasugi and Schimmel. Some of you may know those names, and it came out in Science. I'll talk about it later on, but hold that thought. So the point here is that the synthetase positive patients, Joe versus non-Joe, I'm not going to read everything there, but keep an eye out for these patients because they may not have the classic features that you know how to diagnose, and you still have to worry about pulmonary morbidity. So what about treatment? Let's talk a little bit about treatment. Hopefully I'll come back to what you asked earlier. Non-biologic treatment, look, these patients get hit with steroids. We know that, and Cytoxan does still work. Imuran can work. There's nice data now, evidence-based data looking at MMF, all right? I think if you're going to pick an immunosuppressive, non-biologic immunosuppressive in a patient with relatively mild disease, you want to cool them down, think Cellcept, okay? And then, of course, there's the question that you asked about tacrolimus. And the question I asked you is, does anti-T cell therapy make sense in myositis-associated ILD? Well, it actually does, which is why I looked and wanted to look at tacrolimus on these patients 15 years ago. So you see lymphocytes and plasma cells in the lung of PMDM patients. They form these lymphoid follicles, okay? You get, just want to make sure that isn't me. You get infiltrating lymphocytes in NSIP, okay? And this is old data, activated T cells. So again, there's T cell things going on there. You get CD8 positive and activated T cells even in the BAL fluid of these patients, again, reported a long time ago. And you get a decrease in regulatory T cells in in the interstitial pneumonitis of CTD-ILD. So there's some evidence out there from years ago that the T cells are involved in ILD, myositis-associated ILD. So what did we have at Pitt? We had the opportunity to use tacrolimus. Why? Because Pitt was a big transplant center. So all those years ago, I thought, well, geez, maybe we ought to try looking at tacrolimus. So 15 years ago, with a fellow, one of the best fellows I've had, Meg Wilkes, we said, it's retrospective, but let's look at our data. Okay, let's look at the data we have on tacrolimus. And indeed, we looked at these patients, and it was retrospective, but it was all synthetase positive patients. Okay, their lung parameters got significantly improved when we looked at it, and even their muscle stuff got better. Steroid sparing, CK got better. So so tacrolimus works in the. I mean, and it was not prospective study. We've never been able to do a prospective study. Nobody would fund it. And then, sure enough, after we reported it, Takata, others over the years have reported on the efficacy of tacrolimus, cyclosporin. Now, as you know, tacrolimus is a kind of like I guess it's an anti-T cell agent on steroids, right? It's a better anti-T cell agent. So I think that drug works. Does that answer your question? Now, it might work in other subsets as well, but I do think that there's evidence out there now that it works in myositis and ILD. And I have some guidelines that I always share because it's a tough drug to use. We've used it. I mean, how many times have I used it? Probably 25 or 30 times now. But you have to follow some guidelines. You have to check levels. You have to check trough levels. These patients can get nightmares and hyperglycemia and tremors and kidney disease. So you got to watch it, but I think the drug does work. So if that agent works, then why not study abatacept, right? Which is an anti-T cell agent. And indeed, that's what we're doing right now. We're doing an abatacept trial to treat synthetase positive ILD, and that's being run by Rohit. We're in the middle of it, and we've got Cedars-Sinai, Brigham, us, a couple other sites that we're trying to see if abatacept works for myositis-associated ILD. We don't have the data yet. Well, what about other treatment for ILD? It's interesting that rituximab is a hot drug. Even though my RIM study was negative, Genentech made a lot of money off our study because a lot of people use rituximab for myositis. And there's nice data now on rituximab in anti-synthetase ILD. Okay, and this I kind of shortened it here. This is a nice little cohort of 112 patients, and I believe it was Norway or Denmark. I can't remember. But it was used to treat severe ILD. The issue is that nobody got monotherapy with rituximab. They had a lot of other immunosuppressive agents, many of which included cytoxins, so there was infection. But the point is that this was a pretty good study, retrospective, not done prospectively. And what happened was, if you look at the data, their data, the PFTs, there was a 24% improvement in FVC, 22% improvement in FEV1, 17% improvement in DLCO, all better from baseline. They had this scoring system for the HRCT. It got better as well. In other words, they graded it. Okay, pre and post. 50% grade down to 33% grade, which was felt to be significant. And in 5, the ILD involvement improved greater than 60%, and only 1 patient was transplanted in this group. The Jo-1 levels that maybe come back to what Keith was asking about, the Jo-1 levels actually dropped as well in this cohort that they looked at. And then after this, there have been other reports of rituximab B-cell depletion improving patients with synthetase positive ILD. About 15, 16, and we did a collaborative study with the Brigham a couple of years ago on the effectiveness of rituximab in these patients. So, you got tacrolimus, you got rituximab. There are options out there that you have to think about, beyond just throwing Imuran at these patients. So this is, I'm not going to go through this. This has been published. We had a review and we put together this approach to treating myositis ILD. I can give it to you. It's been published if you're interested in it. But you gotta try to think through this in a logical way. The last, what time is it? Oh, okay. So I got maybe 5 minutes. There are other subsets. I can't go through everything. Malignancy has always been an intriguing subset in myositis, malignancy-associated myositis. So are there autoantibody markers? Well, you guys know that now there are. There are autoantibody markers associated with it. What is the autoantibody marker? It's an anti-E155-140 doublet. And the autoantigenic target, again, is this goofy you know, transcription intermediary factor 1 gamma. You know, so here we have this theme of polypeptide synthesis, okay? And what happens with this anti-TIF1 gamma provides a doublet, okay? They got skin disease and they have malignancy. And just a brief summary of that antibody, in adults, they get skin and cancer. In kids, same antibody. In fact, it's one of the most common autoantibodies in kids. It occurs in a third of these kids. None of them have cancer. And even if you follow these kids down the road, they don't get cancer down the road. I can't explain it. You know, smarter people are going to have to explain it. But we were seeing at Pitt was the fact that this is the most common antibody I see in the clinic, all right, TIF1 gamma. But my patients did not have malignancy, even though we participated in studies where it clearly is a malignancy associated, but most of my patients did not have it. So we want to look at it a little bit further, and ELISA, one of the basic people, helped us to develop an ELISA to TIF1 gamma, and we looked at our patients, and we had a comparison group. So in healthies and JO1 positive patients and RA, scleroderma, you don't have the antibody. And then look over here in myositis. And I said, well, does the titer make a difference? So that's what we looked at, and it says, do the quantitative ELISA titers predict cancer-associated myositis? And in fact, it seemed to. Well, this is reported 8 years ago, and we've never published this for different reasons that never panned out. But the TIF1 negatives, they don't have much cancer, okay? The TIF1 low positives, not much cancer. But these patients with high titer TIF1 gamma, that seemed to predict a higher frequency of cancer, as you can see over here. And it was significantly statistically different from the other cohort, which is interesting and bears a lot of follow. In other words, can you follow those titers over time? You know, it brings up a lot of good questions, but we haven't answered them yet. So just in the last minute, you know, how are we going to guide therapy in these patients? Well, I think you got to, you know, these are heterogeneous diseases. That's probably part of the reason why the RHIM study failed. There's a lot of heterogeneity in these diseases, and you kind of want to, you know, maybe it's better to segregate it and study, you know, to split instead of lump and look at autoantibody subsets. I don't know, but we have to look at interferon signatures and all kinds of things, you know, and maybe we had to approach it sequentially. Maybe in the beginning of the disease, it's going to be amenable to one form of therapy, and then later on it's going to be another form. I don't know. I'm just saying that we got to start thinking things. And of course, I didn't even talk about exercise, but exercise is anti-inflammatory. And Ingrid Lundberg has nicely reported on exercise leading to proteomic changes that are improved, you know, and other molecular changes that actually get better with exercise. So exercise is anti-inflammatory. This is our group. You know, this is we've been fortunate to have Rohit on board now for a while, and CMAC, and Dana Asherman was just recruited back to Pitt. And he's done basic work in myositis. This is our myositis team. We've got lots of, I didn't even put up all the collaborations up there, but we have lots of collaborations. And we just did publish a book. You know, I'm not kind of goofy. I don't want you to, I'll tell you to go buy the book. Well, you can buy it if you want. I'll probably get a nickel for like every, I think I figured out how much I got paid per hour, what they paid me. I think it was $10 an hour. My wife said that was just terrific. You know, you got $10 an hour for doing this book with Rohit. But this is it's out there now. It's out available a couple weeks ago. It's 35 chapters, a lot of experts. So it really does help you manage myositis, and that's the cathedral learning that you were asking about. So I can answer more questions and. Yes.
Other question was about whether you think there's a role for autologous hematopoietic stem cells in this kind of refractory.
Yeah. Okay. Good. Two good questions, Michael. The first question was, where does biopsy fit into this whole picture? I think, as I told you before, I think every patient that doesn't have a DM rash really, and I don't mean to be dogmatic about it, I think they need to have a biopsy because you can be surprised. And you guys are the one that is going to teach us how to be surprised. You or Dave Lacomas, who I work with at Pitt, because there's weird mimics out there. So we have to do that in PM. The next question is, what about the biopsy? I mean, just in terms of pathogenesis. And I think we need to have more novel approaches to that, Michael, in terms of people that have basic science interests. I mean, look at what Greenberg has done, looking at the interferon signature. I talked about that to your group yesterday, and I didn't put it up today. I mean, we can learn about the pathogenesis of even, hopefully, untreated patients by looking at the microarray, see what's turned on. Even get it, muscle is not, it's not like doing an endomyocardial biopsy. You can peripherally get cool. I mean, and Dave Lacomas, who we've collaborated with, they do needle muscle biopsy. You don't have to go to the operative theater every time. You can do needle over time and see it. So I hope that answers your question. I think we have a lot to learn from that. I'm not a basic scientist, but I think that I'd love to know some questions on how to, and then we can see the effect of treatment too. If you B cell deplete, what happens to the.
Whether that antibody could be a standalone diagnostic.
Yes, that's a great question. I don't know but those are the questions that are going to be. And your second question was, well, what about stem cell?
We have a program at the U to do that for refractory autoimmune.
Yes. Do you have that? Okay. What diseases are you studying? Like anything refractory that's autoimmune? Stiff man syndrome persons. Yeah. I can't imagine either. And I think we should, and there's programs at Pitt. In fact, scleroderma lung is another one where it's being looked at. But I don't know, Michael, I agree with you. It probably is gonna best be addressed by a multi center to get the appropriate numbers and to get people interested in funding it, but I'd love to be involved with that. Yes. Thank you.
I was wondering, one issue we run into a lot, especially in the inpatient setting, is timing of treatment initiation relative to getting the muscle biopsy.
Yeah.
Do you think that you need to hold off on starting treatment to get the biopsy? And how quickly does the histologic
there's not great data on that. Like a good example might be GCA. If we pick another disease that we see, giant cell arteritis, and my tendency is that start treating and get the biopsy done. Don't wait a month. But if you're and sometimes people are going to say, well, if this is classic dermato, I know what the diagnosis is, and I can't argue with that. But from an academic perspective, you're not doing a super aggressive thing. So I would tend to get the biopsy done as close to the initiation of treatment as you can. You have that looked at. Michael looks at it with his neuromuscular colleagues. They at least, and then you learn from that. You learn, well, geez, this one has more B cells than more perivesicular atrophy or something. So we learn from that. We kind of put it into our repository data bank and take it from there. But I don't think you're going to have a big deal by delaying for a few days. If that's the question, I really don't. Yes. Yes, yeah. So the issue is who's going to get cardiomyopathy is actually not that common in even in my patients that I see that are severe. But we do an echo for a couple of reasons, and one of the reasons, of course, is PAH, pulmonary hypertension, as well. In any of the synthetase positive patients, or actually any of the patients that have a potential for lung involvement. But I do an echo, and sometimes in those patients that are synthetase positive with ILD, I will follow yearly echoes. But as far as finding, it's rare, but we've seen a handful that have cardiomyopathy. In fact, it was originally reported that SRP patients have an increased frequency of cardiomyopathy. We haven't seen it much. The NIH reported it, but I think it's something to consider.
Rapidly progressive ILD?
Yes. Oh, okay. Yeah, I think that's a good. So the question is, you got a patient that's declared themselves. You're saying they've got bad ILD. You're gonna think I'm crazy. What I recommended to our colleague whenever he sent me that picture, I would give patients rituximab and cyclophosphamide, pulse steroids, and maybe even IVIG or pheresis. We have saved just a handful with a very aggressive regimen. And of course, you're going to say, well, you could kill them with infection, and I understand that. But when you've seen these patients circle the drain and fall off the edge of the cliff, you know, you're sensitized to that. So yes, it's aggressive. It's cyclophosphamide and rituximab. And then you can say, how do you time it? Well, what I basically would do, I'd pulse them. I'd pulse them with steroid. And then I would give a first dose of rituximab, and then I'd follow it with, and you can give IV or PO. I would tend to give IV, intravenous cyclophosphamide. And then 2 weeks later, after putting them on IV, maybe monthly, you know, maybe there's other ways you can give IV Cytoxan. Then I hit them with another dose of rituximab 2 weeks after that. It's a 2-dose regimen, the RA regimen. And then watch them like a hawk and hope they get better. And we've had a couple saves. Yeah, was it an Asian from Japanese? Yeah, right. And there's some data that's going to come out on using tacrolimus earlier in these patients. So that's another option, and we've contributed to that. So I think it's, yeah. I mean, there's options that we can do. There comes with, you know, we just don't have. It's just my guess. I mean, it's art than science. I hate to say that one's favored when I don't have the data to back it up. You know. Oh, it's brutal. It's brutal. I mean, when it hit me, it was in like early 90s. And why did I jump on this bandwagon? I remember talking to people and I said, you know, ILD is gonna surface in our specialty, and we better be ready for it. He is my secretary's neighbor, you know, whose daughter just started school at John Carroll, and she saw me on a Friday and she was dead the middle of next week with Jo 1 positive disease. And you never forget that stuff, you know. And that's what those, you know, our careers are driven by, the sentinel types things that happen, or seminal observations. And that was one. And you think that over 25 years, maybe I'd be able to do better. I haven't, but. Okay. Other questions? Okay, thanks. Good group. Came up a couple times. Hi. I just realized that being able obviously the one off we used
yeah. I got I think Dr. Weisham sent me an email about something like maybe you guys could hear something over the mic.
There was something, there may have been somebody on Zoom who didn't have their
like muted. Okay, so I'll look into.
Goes out on the Zoom announcements.
Please mute your mic.